So firstly, thank you very much for coming along this morning. We're delighted to be able to host this event from the ADAPT Centre in Trinity College. But really we're excited about today. Today is all about learning from the last 2 or 3 years and the innovation that we've been having in technology, in AI, in health informatics, in healthcare in general. And to really do some planning for the next 3 years, to look at where can we really be innovative? Where can we really bring together the multidisciplinary teams that are really needed to shape the technology for healthcare and the health pathways of the future? Today in the audience, we're bringing together experts from artificial intelligence, from natural language processing, from machine learning, all of the AI side, but we've also got the clinical side. We've also got the medical and professional healthcare side and the hospitals. And we're trying to really find places where we can really drive innovation and drive research and excellence to produce the solutions that we know we need. I'm always saying that one of the problems with artificial intelligence is that people tend to think of it in terms of developing it in the abstract. Really, we need to shape the technology to suit our needs. We need to get ahead of the technology to be able to suit the particular circumstances and contexts that it really empowers us. And today is about that. I'd like to focus today on and introduce the ADAPT Centre. ADAPT is an SFI Research Centre across 8 universities with over 100 million over the 6th year of his life in terms of to drive that innovation, to drive that research excellence, and specifically focused on next generation artificial intelligence and digital technologies to see how we can shape the future, but shape the future for the human. Put the human in the center so that we can actually produce solutions that really are shaped for our empowerment. The center today is delighted to be able to welcome researchers from so many different disciplines, from the computer science and engineering side that I come from, but also from the health, also from psychiatry, also from medical, also nursing, as well as aspects of business economics, which is really needed to be able to shape the futures that we're talking about. So with this view, I'd just like to pass over to our MC for the day, Olivia, who will keep us all on track in timing. Thank you very much.
My name is Olivia Waters. I am the Communications and Marketing Manager here at the ADAPT Centre, and it is my great pleasure today to welcome Professor Philip Nolan, Director General of Science Foundation Ireland. We're all very grateful, Philip, for the hard work that you did during the pandemic and keeping us all safe. And we're delighted that you have taken the time out to deliver our keynote address today. Thank you.
So listen, what I'm going to do in 15 or 20 minutes, and I'll run through it very quickly, is first of all tell the story of one group's interaction with Irish health data, if I can put it that way. And there's no particular, there's a lot of experience in this talk, but no particular expertise, if I can put it that way. This isn't from the perspective of an expert. This is actually from the point of view of the human that you're trying to put at the center of how AI might be used to maximize the utility of our health data. So I want to tell the story, the challenges, and what we achieved, because I think our story highlights or illustrates the fundamental challenges that we face in terms of using health data of any kind, but in particular population health data in some kind of meaningful way to guide policy or to guide individual decisions. I'm going to conclude with kind of a very crude manifesto for health data, so take this as a layperson's view almost about what I think we need to do. And it doesn't really set a research agenda, but I think there's an implicit research agenda in it, that if we start to tackle the problems that I conclude with in a research manner, that we might see some emergent possibilities for Irish health data. So just to tell the story, I could tell this a variety of ways. One way is to say that I was called up by the Chief Medical Officer at 8:30 on a Sunday morning And I knew there was a national public health emergency, but I was still unimpressed to be called to say, look, do we have a group of people who do mathematical modelling of infectious disease? And in truth, we didn't. We didn't have a national infrastructure for advanced biostatistics or for mathematical modelling of infectious disease. There were patches, but they weren't connected in any way. So we very quickly convened an ad hoc group at the request of the Chief Medical Officer to support the National Public Health Emergency Team with the terms of reference to monitor and model the COVID-19 pandemic. And we were immensely fortunate in the talent that we had in place across the system. And that talent was there because of individual and strategic decisions that were made by universities and science funders. I think it's really important to remember that. And it's right across the disciplines from applied mathematics, so referencing people like James Gleeson in UL, statistics, Cathal Walsh, Brendan Murphy in UCD, Cathal Walsh in Limerick, Brendan Murphy in UCD, computer science, your colleague Jim Duggan, who I think is in the ADAPT Centre in NUI Galway. Right out into another part, we had specialists in public health on the team, we had epidemiologists on the team. Most of the epidemiologists were veterinary epidemiologists because vets still care about infectious diseases, whereas human epidemiologists are very focused on non-communicable disease. And the membership grew dynamically over time. 50 seems like an unmanageable group, but because everybody was focused on a task, it was very manageable. So we pulled this group together. And I'm just going to highlight 3 lessons that we learned in the course of managing the pandemic. And you know these things, but in a way it was kind of shocking for us just how difficult and primitive some of these issues were. So our health, and in particular our public health data infrastructures, are very poor. And let me say the first thing here is that before I say anything critical, the work that public health professionals, specialists, now consultants in public health, surveillance scientists, health protection surveillance centre, the work that those people managed to do with really old and not, to say not fit for purpose is an understatement, systems was quite extraordinary. So people overcame the challenges of the infrastructure and in quite an extraordinary way. Our approach to data governance is incredibly conservative, and this was an impression I had, but it's backed up by quite a number of international reviews. And then in a way, this was a happy accident. We had to assemble a team. We consciously assembled the people we had who might be able to help. They were by default interdisciplinary, or from multiple disciplines. We were engaged with the problem. So from the applied mathematicians and computer science perspective, and you'll be familiar with this from your clinical and health collaborations, we were focused on their problem and their expertise, and there was an equity in perspective across the group that, yes, the mathematicians were the mathematicians and they could do things that we as kind of public health or health people couldn't understand, but there was a reciprocity that the mathematicians and computer scientists understood and accepted the expertise and critique, particularly in terms of outputs from other members of the group. So, you get a phone call on Sunday, and then on Monday I start to say, well, what data can we pull together? And for a while I was doing this myself, with CSVs and integrating them and, Dippler, left join and all that kind of stuff. So we had cases from the Health Protection Surveillance Centre on something called the Computerized Infectious Disease Record. Maybe CIDR, some of you may know it. The fact that it has computerized in the title tells you the era when this system was designed. I have to say I was an adult when people were talking about, let's computerize this, and everything started with C. It's an ancient system. It's designed to cope with outbreaks that are small in scale, a measles outbreak in Skibbereen or something, and you'll enter the 35 cases in essentially a flat database. We separately then start to get hospital admissions from the HSE Special Delivery Unit. Fortunately, in advance of the pandemic, our colleagues in ICU working with NOCA had put together a bed information system. So again, almost not by accident, it was by design, but not anticipating a pandemic, we had data. But none of this was in any way linked. We had no way of saying that case led to that hospital admission and that person then went on to ICU. We had PCR testing from a variety of sources, and the lab system that was designed to deal with that was pre-existing, but no capacity to cope with, 120,000 tests a week going through it and being transferred to CIDR. There was a whole new system had to be set up to deal with the contact tracing, and by way of designing a system in an emergency to deliver and support the process of contact tracing, it was excellent. From the point of view of taking that data and using it and integrating with all the other data, it was terrible because it was designed utterly in isolation. So it served its focused purpose and frustrated the wider purpose. And the same thing happened again when antigen tests came in. So we are literally taking the population of antigen tests and the population of confirmed PCR tests and have no way of knowing which are the duplicates. So we just have to count it all. And then of course we had whole genome sequencing data, which we did manage to integrate into the CIDR data, and vaccination. All of these were separate, no ability to link them. So all we were doing was observing a phenomenon in one population set here, and other phenomena in other population sets, and couldn't take a patient journey through those. So you're familiar with all these. But just to say, even in 2021, in the middle of a crisis, we are dealing with data that are incomplete because people don't have the time to fill out the parts. And every time they come to a new part of the system, they enter it all again. Therefore, most of it gets not entered. Delayed because of time, unlinked, and not geocoded. I mean, we have a national geocoding system, and again, because people say, do I really have to do this? Is the attitude right across the system so the error code doesn't go in? The colleagues in the HSE were incredibly facilitatory, worked really hard to share the data, but they had constraints, legal constraints and perceived constraints. And it was very slow to negotiate the data sharing agreements. If you need a system quickly, don't ask the designer to integrate it with other systems, so systems are not integrated. And we have a long-standing failure, and I always have this image in my head of the famous public services card narrative, that rather than stand up in the Oireachtas and say, look, citizens, we need to know who you are across our many different systems, so we're going to pass a law and we're going to talk about it and we're going to use your unique identifier in different ways. We kind of tried to slip it in under the radar. Well, we didn't. Somebody tried to slip it in under the radar as a public services card, and quite rightly, citizens went, hold on a minute now. You're not going to do that and we're not going to use it in that way. So it's hugely unfortunate that when people present themselves to different state services and different health services, there is no way of identifying who they are across those multiple services. And there's no way of identifying. We don't use the way we have of identifying where they live or where the incident happened. So look, nonetheless, and I just kind of want to make the point that you have to do what you can do, and I'll move very quickly. We did manage to gather the data together. We did manage to integrate it, and insofar as we could remove duplication, so we could monitor the thing. So that's what's on the left there. That's the daily kind of detections per day, because we did eventually get to a way of figuring out who was first antigen tested and then PCR tested. And we could look at the variants. So we were, in terms of whole genome sequencing, we were as good as most other developed nations. So that's the right-hand figure showing the different variants come in. And in the early days, this was all we could offer. So this is from late March. We could say, okay, we can see how many cases there are. We know we're in the early stage of the pandemic. We know there's no immunity, so this is going to grow exponentially. And it was kind of a guess. And the black line there is the unmitigated growth. It was growing at 33% a day exponentially in early to mid-March, and if the lockdowns hadn't occurred, then that's the track that we would have followed. And then we were simply going, okay, well, let's, if we reduce that to 15, 10, 2, this is what it would look like. And in one sense, that's trivial, but in another sense, what we were doing here is explaining to government, this is how it works, you know, so you may be here today, but you'll be twice that in 3 days' time and twice that day. So like explaining exponential growth was the first step. Just want to make a very quick point. At that point, then somebody says, let's build a model of this, but we didn't know anything about the disease. We didn't know what its latent period was, time from infection to time when you start to shed the virus, generation time, the interval between one case and the next case. So, and I make the point again, these are a group of veterinary epidemiologists who did what they do really well. They're risk analysis people, so they systematically reviewed the literature. They put a team of 20 students on it. They read everything that was coming out. They rated it, and they said, okay, and what you're looking there is in the chart, you can see the forest plot at the top, which is a whole lot of estimates of incubation period, and then a probability density function of, well, what's the likelihood that the incubation period is 4 days? That's the maximum probability. So this was an essential piece of work, and it's one of the things that I want to kind of suggest is one way of making artificial intelligence human-centric is to rely on this well-established other way we have of understanding what's going on in the world. And they did the whole thing for us. These were published much later, but this was done in 2 weeks. We were one of the first countries to identify pre-symptomatic transmission, that you can transmit before you're symptomatic, because these people were beavering away and say, look at the generation time here and the incubation period. It looks like you transmit before symptoms. And we're literally sitting there going, oh dear, because, well, we know, yeah, that was a heart sink moment. So just want to emphasize the importance of that. That's institutionalized in our country through HICWA, and people are trained through a structured doctoral program that the HRB runs here. So you're probably aware of all this, but just remember that resource being there as a validation, well, a parameterization and validation tool. We used it for parameterization, which got us to this point, where we could develop really good population-based models. This is one we used after the January 2021 wave, when government was thinking, okay, well, it's past now, can we open up while we're vaccinating? And what we were showing here was, if you do it too early, April, you get a massive wave. Wait 4 weeks, I think, yeah, you get some wave, and wait 8 weeks, and you get not a whole lot indeed. And that persuaded them just, you know, stay home until you're vaccinated, basically, and the vaccine passes emerged out of that. That was James Gleason's work. This is Jim Duggan's work, who I mentioned earlier. Jim did a huge amount of work that only a hardcore computer scientist could do, which is to take that model and age cohort, to treat children, adolescents, young people, older people differently. Really difficult to build, but what you're looking at here is if children don't transmit as much as adults in the green, and if children and adults transmit the same in red, with different, the lower one is kind of a hard lockdown scenario, and the darker one is opening up, and you can see the actuals in black follow the low child transmission ones. We're able to use that in kind of September, October, December 2021 to kind of calibrate how we opened up in schools and all that kind of stuff. So it was a brilliant piece of work. But what do you notice here? Because all we're dealing with is population data, we know what proportion of the population in essence are becoming infected. We know what proportion of those infectees end up in hospital. We've no individual data. So this is just whole population, or cohorts of the population. It's kind of a big black box. So what we can't do is any kind of granular analysis or spatial analysis. So to bring me back to this point, our inability to integrate data from different data sets, the fact that we are missing any useful geospatial data meant that our ability to do this kind of stuff, fine-grained analysis of where the disease is spreading, this is done by Jamie Madden, who's was used to he's funded to look at tuberculosis in badgers, but COVID in humans, same code, more or less different parameters. So, you know, the stuff that you might have seen emerging out of the UK, what districts, what socioeconomic groups, really difficult to do. The CSO could. The CSO could suck the data into the massive security of the CSO. They could take data from revenue. They could find out what your job was. That's not available to the rest of us, so they did their best to make it available in the CSO Data Hub. So they could do infection risk by socioeconomic group and occupation. And then Insight deployed Aidan Boren with Mark Rowntree and then Matthew Dacan, who was in Galway, into the HSE. So again, you'll know that sometimes the only way to get data is kind of commando style. You parachute somebody in and then you have access to the data. And they did some extraordinarily good work, but it was too slow and too late, and that's no offense to them. They knew that, on formal data engineering approaches to integrating the data sets and produce synthetic data. So if we'd done this from the start, or if we'd done it in anticipation, then we would have had integrated data sets. We would have had synthetic data sets to test the work on, and then we would have negotiated, I'm sure, secure access. The other thing that I want to highlight is the COVID-19 tracker app, and I know you were involved. In one sense, it was a great success. It did interrupt chains of transmission. It did support contact tracing, and it did provide a platform for other things later. But it was also a missed opportunity, and the missed opportunity was, what we did was we took this conservative or fundamentally privacy-based, this is our priority. We'll assure citizens up front, we'll engage them, but we'll engage them on the basis that, don't worry, your data's perfectly secure, it's a distributed architecture, nobody will ever see it. We didn't say necessarily to citizens as much as we should have, it might be a good idea to share this data more than you think. So we started by reassurance, we won't do X, not should we do Y. And it was also not adaptive. It was, this is the governance arrangement. Are you assured? Off we go. And internationally, of course, the experience was that people were assured, and they said, yeah, okay, I'll download that, and then didn't. So you had 75% of people saying, yes, I am willing to download this app, I think it's safe, and 25% of people actually downloaded it. So you'll be well familiar with this. There's a whole other science to getting people to adapt these things. What we lost was, if we had done it a different way, we could have had anonymized location of exposure. We could have said, okay, this person is pinged in this place. We don't need to know who they are. We don't necessarily even need to know the precise location that would be useful. It's the category of place that matters to us. We lost data on population movements. We were trying to calibrate models where we said, how many other people does a person bump into every day now? And that data would have been extractable from the app. If you had the app live, and if the number of contacts per day you had could have been uploaded. So if we factored all these things into the design, we could have got a lot more. So we could have had, as I say, dynamic contact matrices. We could have said on any given day, this number of teenagers encounters this number of 65 pluses, and the risk associated with that is whatever. So what points am I making? So one of the things I had a list of things in my head, and I've highlighted what they are, and these were the things that bothered me. And then I looked for a couple of reviews, and there's a really nice review published in Artificial Intelligence in Medicine about focusing on the challenges for AI in terms of forecasting and modeling. So there's lots of things that AI, as you know, could potentially be very useful in, from kind of image analysis out to improving the sensitivity of testing and so on. But for the thing I'm concerned about, how do we understand what's going on in populations and forecast it? Here's their summary, not mine. This is their summary. Lack of large-scale training data. I'd actually say lack of accessibility to large-scale data at all. We could get traditional data, how many people in ICU and potentially who they are, but mobility data, the big data sets that we'd really like to use, that AI is most useful for, no, you can't have them, they're private, So everybody's walking around with a phone, we know when it's pinging off the mast, but no, you can't have that. So lack of large-scale training data, lack of large-scale data at all, or accessibility to it, lack of data standardization and interoperability, I said, missing data, In our context, the fact that people self-referred for testing, so you didn't know who was negative, you knew who was positive. Lack of interdisciplinary collaboration, I've highlighted how lucky we were to have that, and privacy, trust, and ethical issues. And in governance terms, not knowing how to make those trade-offs. Citizens know well how to trade off their privacy versus their health. And interestingly, infectious disease is one of those areas, and it's for historical reasons. It's one of those areas where democracies allow the liberty of their citizens to be restricted for health reasons. You've got it in infectious disease, you've got it in psychosis. So it's interesting that those threats were visible as common and civil law was being codified. Somebody who's sick and infects you and you may die, they're a threat. So you can, somebody who's psychotic, let's secure them. Other threats to human well-being that have emerged in the last century, we're not sure what to do about the trade-off between individual liberty and harms to populations. So, and at the moment, our view is, and actually, it's very much dominated by public fear of private accumulation and manipulation of data, that we have this very conservative, anyway, that's what. So final slide, in terms of kind of ambition for Irish health data, I think the first thing we need is a national open, we need to have the public services card debate, frankly, a national open, person-centred, this is your data, it's for you, how can we use your data to make your lives livable and more better? And it needs to be adaptive, and I'm using the word adaptive in the formal sense of adaptive governance approach. I think, and this is where I see a research agenda in it, I think we need to think about data. We have legacy health systems. Somebody isn't going to arrive with a new perfect system that joins everything up. We need to start somewhere and say, what can we do now with good formal data engineering? What are our priorities? But we do need to deal with the individual health identifier issue. I'm not quite sure how to get in the door with that and the use of air code. Archiving and access is going to be, and again, there's a governance research agenda and a technical research agenda that are joined up there about the pandemic data, for instance. Where is that going to go? And who's going to use it to prepare for the next pandemic, and will they be able to access it? And then finally, in terms of how I see the research agenda, I think we need to think about taking some national priorities here in terms of research questions that are important in themselves, that really push the boundaries in terms of how we use health data, and we get on with those pieces of work. We fund them, we require them to be interdisciplinary, we require them to be engaged, and what we're doing is not just answering the research question, but we're building the capacity to mount the kind of responses that we saw earlier in the presentation, but in a better way. That's it. I hope I haven't gone on too long, and I hope that last slide in particular does help set some thoughts rolling. Thank you very much indeed. Good.
Would you like somebody to?
Yeah.
If anybody has any questions, Professor Nolan would be happy to take some.
Stunned.
Is there any evidence-backed kind of claim that, like government was putting up some lockdowns, like 10-kilometer lockdown, you can only go in 10-kilometer, or then you can go in like 5-kilometer area? Like, is there any evidence-backed claim like that 5-kilometer lockdown was better than 10-kilometer lockdown, or that sort of thing?
So, how should I put this? Ex ante, in other words, before it, saying, what are we going to do? So you're sitting in a room somewhere in government buildings to say, this thing is spreading uncontrollably, what are we going to do? Stop people moving. And there was no evidence for any particular form of restriction to say, in Italy it was, you can't go 400 meters from your home. 400 meters, I don't know where that came from. 2 kilometers, 5 kilometers, county. They were simply crude, almost signals to the population about how much they needed to restrict their movements. So now that's ex post, one of the things that we should be doing, and the data is probably there, just not yet integrated, is dissecting out the impacts of those different interventions. And of course, there was multiple interventions at any given time. So there wasn't an evidence base, but there was a rationale. One of the most extraordinary ones, of course, was the closing the pubs at 5 p.m., 8 p.m., and people going, does that mean it only spreads after 8 p.m.? Of course, no. What it means is there's the opportunity for social contact, and if you reduce the time by half, you're going to reduce the opportunity, not necessarily by half, because yes, of course, well, I'll go out now while I can, but you will reduce it. And that was, I don't know if you know this, was memorably replayed by the Taoiseach on the Late Late Show, where he announces to the nation, well, Philip Nolan said, like, if you could just get social contact down 30%, I was afraid going to my local pub for weeks afterwards. But so there was a rationale, but not an evidence base, and I think there's an obligation now to go back and look at the impact of these different measures. It's Cliona and one, and then I should stop because there's a panel.
This is fascinating, Philip. I'm really interested in how you refer frequently to the citizen.
Yeah.
But I'm also interested that the citizen, our communication with the citizen doesn't appear here on the research agenda. I would have thought Ireland did particularly well in this arena, but we made some mistakes. How do we again learn from the past and improve?
Yeah. So you're absolutely right, Cliona, and forgive me. The citizen is, and one of the things I was actually trained not to use the word citizen because, of course, some of the most vulnerable, some of the most vulnerable people we're dealing with were not citizens. Yeah, so we have to go back to the very simple people. We need to engage with people. That's buried in the word adaptive there. So, and I should have expanded on it a little bit. Colleagues here will know what adaptive governance means, but adaptive governance is governance that enables social learning. It's not seen as a control structure or a limiting structure. It's seen as how do we get people together so that we can do this as best we can now and learn how to do it better. And then by definition, adaptive governance is inclusive governance. That you are brokering an agreement with people. And governments are sometimes uncomfortable with that because governments, just as an analogy, why would we need a citizens' assembly? We have a parliament. And of course, we need a citizens' assembly because it gives another mode of conversation than the parliamentary mode. So it is hidden. It should be more overt, I agree. It's hidden in that notion of adaptive governance that where you're distributing governance across a lot of stakeholders, including individual people, in order that you can learn as you go and adapt as you go. That's kind of, in essence, one of the tragedies of the app is that governance was a rigid thing and we couldn't halfway through say we could use this differently if people would just agree to use it differently. And there was another question here and then I'll stop.
Hi there, Katrina Creeley from the Health Research Board. I work on data infrastructures and personalised medicine. Very interesting talk. I just wonder, would you like to offer a perspective on the health information bill that's currently being developed by the Department of Health, addressing some of these issues such as the health identifier, potentially using the PPSN number? If you'd just like to comment on that and how you could see that having an impact on the research agenda as well.
Yeah, so it's not really my area of expertise, to be honest with you, but it is a positive step. I think having an Oireachtas conversation about how we use health information overtly and saying that to people, this is your identifier. And like as I say, the CSO are authorised to use it. That's how they did that data matching. And we were capturing PPSNs for a variety of health purposes. But then health actors couldn't use the PPSN. CSO could use the PPSN. So I won't comment further because the kind of legalities of it are not my area of expertise, but it's the right conversation to be having. The big question about the health information bill, is there room for adaptation within it? So what's in the bill and what's going to be in statutory instruments afterwards is for me the big question. In 5 years' time, we go, actually, we shouldn't have been that restrictive, or we need to restrict. How is that going to happen without going back through the whole Oireachtas piece again? So for that kind of legislation, in one sense, the simpler the better, that the legislation sets principles within which the minister and government can operate, and there's boundaries on the operation rather than trying to specify out the detail of how they should operate permanently.
For one more question.
Okay.
Yeah, no, I just, thanks Philip, no, that's really interesting. And I think you shone a light, I suppose, coming from a health service perspective in relation to data and the power of data. And I suppose I was just thinking, moving forward in relation not just planning for the next pandemic, but how do we cope with the pent-up demand? Can you see how the universities and the health sector should maybe work closer together, or is there some synergies there that should support that?
Yeah.
It's about the lack of data and how we use it in the health system.
Yeah, I do actually, but they're ill-formed. And so I'll tell you where I'm starting from, because I kind of have a responsibility as a research funder now to do something about this. So principle one that I'm dealing with, and this is a bit like therapy, Number one, don't let it overwhelm you, because that's the first thing that happens when you talk about we need to do something about health. It's too big, it's too old, it's too expensive, it's too difficult to change. So don't let it overwhelm. That's number one. And then number two, learn from what happened here. And what really happened here was there was a compelling problem, which is quite limited. I mean, we weren't dealing here with waiting lists and the PACs and stuff like that. So limited, important problem for which there was a multidisciplinary committed team assembled behind it. So my sense, and without putting the HRB on the spot, my sense is that we as a funder and the HRB as a funder, working with our parent departments, need to think about what are the key problems, the manageable problems that would have transformative. That's what I was trying to allude to at the last point there. If we could pick half a dozen really important problems that people that are kind of intellectually compelling, health important, manageable and doable, and the last test then that there be some kind of capacity building. Or the fact that we could do this gives us the capacity to say, right now, the next big problem, we'll step up in terms of difficulty or complexity. So problems that have an impact beyond the scope of the project itself and build capacity. And again, to come back to like spheres, the sphere programs are a really good example of a funder and a system identifying a problem, saying we need to build capacity in it. And then when things went really wrong, we had these highly trained people who did extraordinary work in a very short period of time. So I think learn those lessons and then bite off some meaty but manageable problems that really matter. And we need to think about how that work should be funded. There's one last question, I think.
Thanks, Phil. Derek Mitchell from Manifesto. So it's interesting in the context of Cleon's question. We've been running citizen juries on tricky health topics for the last couple of years on access to health information and just recently on genomics. And there are huge parallels between what we're learning from the public about what the fear is. And I'm struck by your point about the fear of the private influence on this. And I think that there's probably learnings to take for future public-private partnerships, because it strikes me that what you talked about in terms of the lack of infrastructure, the lack of investment in health data, it's going to require some form of public-private partnership to actually implement national level solutions. But from what we've learned, they have to be, as you said, public-private people partnerships. So the citizens and the people in the country need to be brought along with these new models. So I'm just wondering if that's something that SFI is thinking about doing.
Yeah, and with appropriate respect to our colleague agency, the HRB are further down the road of public and patient involvement, genuine involvement and engagement in research than SFI might be. SFI also does it, but not as well or comprehensively, I think, as the HRB does it. It's critical, and it's critical that people understand the role of the private actor and the role of the public actor, and what's in it for the private actor compared with what's in it for the public system. So So I like that formulation of public-private people partnership is a nice way to put it. And there's a long tradition of doing that in health research and an emerging way of doing that in science and engineering research, and we need to meld those, in my view. I should. And one final thing is that normally when I come to something like this, I do stay for the whole thing. I'm going to have to go to a meeting in the Department of Health for 11, so I will slip away, but really enjoyed talking to you, and thanks for the questions.
Thank you, Professor Nolan. So next I am going to welcome back up our Director and CEO of the ADAPT Centre, who is going to talk to us about human-centric AI and the opportunities and challenges with that.
Thanks, Olivia, and thanks, Philip, for a great talk. I'm going to be building on top of some of that. I'm going to talk a little about the ADAPT Centre, but I really want to point out is how we can build these interdisciplinary teams which are taking meaty chunks of important issues and really trying to provide solutions and really try and push it forward, as well as develop a capacity for future engagements, for future innovation. So, ADAPT is really focused on what we call this human-centric AI, where we actually try and think about the individual, the human, at the very beginning of the discussion. So we don't have situations where we get stuck into too much of the data and don't realize this is a person. When we realize these are patients, or these are citizens, or these are just people from the country, where we want to be able to actually empower them. And ADAPT is really focused in on how we can actually look at this digital physical world that we live in today. We take it for granted that if we walk down the road and if we use our mobile phones or whatever, that somehow these things get integrated. And we are more and more moving towards this fusion of the physical and the digital world. What that means is we're going to get more and more seamless interaction with the digital and the physical, in whether we're using it in healthcare, whether we're using entertainment, whether we're doing it for work, whether we're doing it for leisure. What does that actually mean? And how can we ensure that the technologies are shaped to really empower us? It's not just about automation. It's not just about manufacturing. It's about us as humans, and how can we be empowered by this? And how can we have the relevant controls in place? How can we feel inclusion? These are all the issues that came up after Philip's talk. These are important issues that we need to actually embed in the research program right from the beginning. It's not something that's put on at the end. And who's accountable for it all? In ADAPT, what we do is we look at those three different levels. We look at the individual, and we actually look at how technology can really shape and empower them for whatever sort of interaction they're doing, whether it be work, whether it be leisure, whether it be lifestyle. And then we say, okay, if that's what the interactions are going to be like in the future, how can we bring that back and say, well, what does that make a difference for the algorithms? What does that make a difference in the way we actually gather the data? How will we curate that data? Another one, I'll pick up one of Philip's points. An awful lot of data is actually gathered, and the model that has is particularly for that gathering. The problem is you need to uplift that and actually make sense of it and connect it. And what happens is you end up with these layers of data. We need to be able to do that so that it empowers the individuals and empowers the enterprise and hospitals and organizations that use that information. But if we're going to do that, we're going to change society. So if we're going to do that, what does that mean for the enterprise? What does that mean for the hospital? What does that mean for society? And we need to take those risk assessments early. It's, again, when we look at the design of these and we research these, we need to include the ethicists, we need to include the sociologists, we need to include the considerations of what this means. By doing that, you end up with solutions that are shaped for the future, rather than ones which are shaped for a future which may not be the one we want. In the ADAPT Centre, we take those three areas and we bring them together. And this is why we talk about real multidisciplinarity, where we can actually have that reciprocity between the engineers, the subject matter experts, the ethicists, the societal, the risks, and so forth, to actually bring them together, because problems don't come shrink-wrapped. I see, going back 5-6 years in AI, I saw lots of people doing AI in the abstract. We have some data, let's develop an algorithm, without actually thinking in terms of, but what is the impact of that algorithm? How can that algorithm be used in different contexts? And what is the best way to develop that algorithm? You know, we are talking about big data sets, but actually, even when you're talking about those big data sets, you're actually also talking about how can we do more with less? How can we actually use that data more effectively so we don't have to gather it all together? How can we do that processing where it actually preserves privacy, not necessarily bring it all together and break privacy? And those becomes really important issues within the ADAPT Centre, where we're looking at how we can reconfigure AI to suit conditions. How can we make use of sparse data and resources, in particular the unconnected resources? How can they be connected for particular purposes in a very agile way so we can solve the problems rather than waiting for 2 years before the system finally gets developed and then is no longer applicable? I'm going to specifically talk about some of healthcare, but it also affects law in terms of we're trying to shape the European law around AI so that it actually is making some appropriate decisions. It also means we have to try and educate about what AI is, because people still think in terms of AI as almost like a set of rules that the system understands. But actually, a lot of AI is driven on the behavior and the data in which you have. And if that data is wrong, or if that data is biased, or if that data has a problem and not connected in the right way, then you're going to have bad AI. So how to actually build in solutions for that. And the last part, one of the things we do look at is, what does that mean in terms of the future, the way we interact with systems? Because systems, the newspapers a while ago, Google, a particular person in Google actually thought a chatbot was sentient. No, it wasn't, okay? But the point being is that actually we're going to be interacting with these devices and these resources in a different way within 5 years. Our patients will, our healthcare workers will, and we need to be careful on how we actually mold that technology for that future. So we're really looking at, today, looking at how we can empower patients, clinicians, and healthcare professionals and organizations with next generation AI technology. That is pulling from the multimodal information bases that we actually are going to be the future. Because we know that information is coming from images, coming from text, it's coming from clinical records, it's coming from so many different sources, and we're expecting to be able to connect them together. And don't get me started when it comes to immersion, where we have VR and AR and so forth, where other issues become. So how do we actually put that through? And again, with control, with inclusion, with accountability. So we can think in terms of, a lot of people think in terms of this kind of stack thing with the healthcare data, then you've got the machine learning going in there and the AI going in there, and then hopefully you get some research insights. You get healthcare delivery and precision medicine right at the point of that. And if we try and unpack some of that, what that means is a data management infrastructure and data models which are based on clinical records and research clinical records. But we have to come up with better integration techniques. I mean, Philip very clearly explained what the integration challenges were and how disrupting they were for making proper decisions. But it's above that, we want to actually build a semantic layer so that we can reuse that data sets for different problems in different contexts and make it much more amenable. We want to also then look at what are the problems for, in our case, in particular diseases, because we have rare diseases and we've got very much more common diseases. The rare disease we have to pull from so many different places, well beyond the Irish borders, to be able to actually look at those innovations that are needed. And then we have to shape the technology to suit it. And again, I point out here that we are looking at how we can change the way people think about AI and the way they think about neural processing, because at the moment, a lot of it is just, it's either big data or nothing. And actually, that's not the case. And that we have a spectrum of techniques, and we're moving forward with multiple, where we can actually do clever things to protect the privacy, clever things to use the more sparse, or the data that can become less sparse, where we can infill or use synthetic data. In doing that, we have to have the ethicists and the data governance issues up front, because as Philip illustrated, sometimes if you leave it too late, it's too late to convince people that this is a good idea. They need to be part of the solution. If they're part of the solution and the development of that solution, the point being is that they're much more likely to accept it. And getting that through is very difficult. It also means new ways of how we engage with patients, and the last question from Mokosi, our colleague Mokosi, is a really good example of that. So in ADAPT Centre, what we have are expertise from so many different disciplines, from computer science and engineering, but also from the medical side, from the sociology side, from the law side, from the ethics side, because it is that milieu, it is that reciprocity of respect, and it is that understanding that will actually produce the solutions that are shaped for the future that we want. I'm going to just call out one or two examples, because this is a European project led by Mark Little, who's here in the audience. Mark was looking at vasculitis, and in particular, that's a rare disease, so the information is stored in different registries in different places. It doesn't make sense to actually try and bring all that data into one place. What they did was they looked at having different registers and federate them, but do federated learning across them, so you're not breaking a lot of privacy, but you're actually really beginning to look at new ways in which we can actually reason about this and create the semantic model that we can then reason about. So that means data infrastructure, data models, semantic models, and machine learning specifically for prediction and reasoning. But all of the time there was that project, Mark's a really good example of how he did it. It was a completely interdisciplinary project, so that it had the clinicians, it had the patient's voice right from the beginning to actually see how this would actually work. It had the ethics, and it had the notion of privacy and what are those issues. Precision ALS is one which was close to my own heart. I work with Orla Hedeman. And here we have a situation, again, it's a rare disease. There isn't enough data within the borders of Ireland, but we, as part of TRICALS, which is a European consortia of looking at ALS, we're able to have those and draw those information. In this one, it's coming from multimodal data sets, but we actually did try and bring them together because there was an opportunity for that, so that they can be stored as a European resource for research and for decision making. Again, how we actually pull those records together, how we actually build the data acquisition tools and techniques, how we build the semantic models at the moment. The project is only 6-8 months into operation, but we've put together a lot of initial findings, initial data approaches for that integration and for that building of the semantic model. Precision 4Q is a European project run by a colleague of mine, John Keller, within the ADAPT Centre. He leads up our AI work in the ADAPT Centre. And it's really looking at personalised stroke treatment to enable multidimensional data-driven prediction on those. And again, it's again exactly as we talked before. It's looking at all that in multimodal from different sets, being able to bring it together and being able to analyse it and be able to predict over it, to really improve the care and to improve the rehabilitation for people with stroke. My colleague Lucy Hedeman and other colleagues are working closely with general practitioners to really look at how we can actually use patient-generated health data, to look at the data quality of the data provenance and the governance. We can think of that as being actually making the patient as part of that solution, and look at the opportunities for those wearables. And finally, Heletica, which is a research training network. Again, it's about the other thing that Philip mentioned. It's the capacity building. We need these professionals who are able to tackle this sort of work to be able to actually really produce the solutions and develop the solutions of the future. So within the ADAPT healthcare research space, we're so lucky to have so many talented people. And I echo Philip's point. In Ireland, we have so many talented people. When I go abroad, what really is the difference is that those talented people are happy to work together. They really want to connect to be able to move the solutions. That makes a huge difference compared to some other countries. And what we need to do is be able to provide the vehicles that to drive that levels of collaboration. Today's idea was to, when we have someone in the discussion, is to move forward the dial. We know what we've done is some of it is really excellent, but we want to go further. We want to see how can we actually shape the technology for healthcare for the future. And that's what the debate that we want to have. That's what the discussions we want to have later. So with that, thank you very much. Let's go to Dave. you want to go straight to Dave?
Yeah, I might take a question.
Okay, if you want. Okay.
So we have a moment, we're going to patch our next speaker in. We have a moment for a question while that's happening, if anybody has any questions.
Or just
Okay.
overwhelmed.
There'll be opportunities later on as well. Okay, thank you, Vinny. So, our next speaker is Professor Dave Lewis.
Recording in progress.
He's joining us via video link, and he is the head of the discipline of artificial intelligence here at Trinity College Dublin in the School of Computer Science and Statistics. And he's going to pick up on some of the aspects that Vinny spoke on around the data side of things, and the dimension with that in terms of the ethics, the value that's embedded in it, and the governance associated with it. So I think we are almost set.
Okay, good to go, Dave.
Can you hear me okay? Yeah. Brilliant. Thanks for that introduction, Olivia. I apologise that I'm not able to be there in person. Again, COVID's reared its ugly head and I'm still self-isolating in my spare room, but I hope I'll be able to get across a little bit of a flavour of some of the work that we do around the interaction between AI, the value that it can provide, and the government's challenges that it presents to us. So this is a snapshot from some data that's tracked by an artificial intelligence initiative at the Council of Europe, which for a few years now has been tracking the many different initiatives, as they call it, centered around AI. So they're tracking, if you like, the intensity of activities internationally from academia, but also well beyond academia into areas of public policy, documents coming from think tanks, national authorities, professional associations, civil society, international organizations, as well as, you know, a large chunk of academic literature. And I think you can see through this a couple of interesting trends. That from around 2017, we've seen a massive uptick in international interest of issues related to artificial intelligence and, you know, what we could call trustworthy AI. Sometimes people refer to ethical AI or responsible AI. And we see this really as an extension of previous academic work focusing on areas that used to be labeled as algorithmic accountability or data ethics. But essentially, you know, understanding that it's not just the processing of data and issues around privacy, though they remain important, that we need to think about when we're looking at challenges around the governance of data. But it's increasingly how that data is being collected and used to develop AI models, and how those AI models are being used to develop new products and services. And this has thrown up a wider range of concerns about, you know, nearly all aspects of human rights or fundamental rights. Issues of freedom and inclusivity come up, fairness and diversity, the need for appropriate mechanisms for organizations involved in collecting data and using it for AI to demonstrate that they're acting responsibly, that they're accountable, that they're operating above all in a transparent and trustworthy manner. And in ADAPT, you know, we've been interested in this since our inception in around 2015. We had a very similar feeling that this was a burgeoning issue, and we started in quite a small way by, you know, forming links between computer scientists who are interested in issues of AI and data governance, and multidisciplinary colleagues in areas such as ethics and law and social science, as Vinny had mentioned previously. And that has led us to sort of ride this sort of general wave of interest in AI ethics. And in particular, we've been engaging actively at the international level, especially as issues of trustworthy AI become a subject for international technical standardization. So in around 2017, as this was starting to hot up, ISO, which is the main international standards body, and it has a collaboration with IEC to work on ICT standards. So they would be the organization that would be the main source of international standards that are adopted at a national and an international level and are referenced through legislation. In around 2017, working with the National Standards Authority of Ireland, ADAPT got involved in a new standardization activity in that AI area that sort of brought in existing standards where we were active around data management. And Ireland was really at the forefront there. That was a new activity. This tends to get voted on by national standards bodies, such as the National Standards Authority of Ireland. It was initially proposed by the US and China, but on the voting record, Ireland was the third country to support it and was one of the very early hosts of some of the international meetings in this area, and has for a long time actually been providing the convenership, i.e. the chairing of the Trustworthy AI International Standards area within that activity. And that's actually been led for a while by some researchers from ADAPT. So we've been sort of very focused on this interaction between AI and its governance, and how do we achieve a level of trustworthiness in it, and how do we integrate that with data governance for quite a while. And in doing that, we have to really understand how these problems break down. I think, Philip was mentioning that a little bit earlier, that we have often these public private collaborations going on when we're trying to assemble the resources to collect and leverage data and turn it into AI models that provide an application that therefore has some sort of use. And the problem that's often facing us when we're trying to do this in a way that will be perceived as trustworthy by the general population, and especially by the people whose data is being used, is this value chain that underlines this process is often very opaque. Okay, so it's not clear, who's collected the data, who's holding it, who has responsibility for it, how is it shared with the people who will develop, statistical or deep learning models. How do they interact with the organizations that will turn those into applications? They go through a process of research and development, and then perhaps an application comes onto the market, and then it will actually be used. And perhaps, people, possibly clinicians, will be the users of those systems and be, using those to make decisions in their day-to-day activities. And a real barrier is, as we see, is not only do the different stakeholders in these value chains need to trust each other. So, I think again we heard quite clearly from Philip about some of the barriers that we have between different organisations in the healthcare system in Ireland, who have different remits, different responsibilities, being restricted from being able to share data with each other, and probably being, having to exercise quite correct caution in how they exercise those responsibilities. So the first thing we have to do is understand what the value chain we're dealing with is. But then we really, really have to focus, I think, as Vinny was pointing at, to what is the overall societal context. So we have to ask the questions, we're aspiring to use our sort of technical expertise, our clinical expertise, the data that we have available to try and bring AI to bear to provide some useful products and services or useful analyses that can serve the public good, especially in situations such as COVID. but we have to have ways in which we can understand the societal context and understand who are the players there that interact between or liaise between that value chain and society in general. So the first thing we have to understand there is, who actually does bear responsibility? Who are the oversight authorities? And certainly in most countries we adopt what we could describe as a co-regulatory approach to this sort of problem. There's an interaction between people who carry responsibilities within, for example, hospitals or health services or individual companies, and people who are in the public domain. So who have who wield some authority or brings some authority to bear in terms of public scrutiny and governmental regulation. So we have to understand, therefore, who are the actors within the companies, who are the responsible managers, executive bodies. Increasingly, we see in technology companies the formation of ethical review boards. So we have to understand how they operate, and we have to understand how they interact with the public representatives. That could be individual regulators, it could be civil servants, it could be the legislature. As Philip mentioned, sometimes we need to discuss some of these relationships in public forums or in the Oireachtas, for example, in the Irish context. But further than that, when we're having those discussions, it's not just between public authorities and, if you like, sort of governance experts and management responsible bodies within different organizations, but we also have to lend a voice, as Vinny was mentioning, to who is actually affected by the decisions we make, what data we collect, how it's used. So we have to understand what we would regard as the affected stakeholders. So those could be stakeholders who are in the value chain, perhaps they're receiving some benefit from their data being collected, or being a user or getting a benefit from the use of an AI application. But there may also be people who are affected by these decisions but aren't necessarily in the value chain or don't perceive themselves to be in the value chain. And I think the COVID tracker application, I think throws those sort of tensions into quite sharp relief, and that we're trying to gather information from the widest range of people, but not everybody's, at any one point in time saying, well, I'm not ill at the moment, or I'm not in a vulnerable group. So, the balance between concerns about data protection and the benefits or harms from what happens with our data in terms of privacies or biased decisions from AI systems may not be may be different from group to group. And understanding this breakdown means we can start looking at the design of these governance mechanisms, and we can start looking at, well, what are the signals that we can put in a mechanism of governance. So GDPR would be an example. What are the signals that sends from the people who are conducting the oversight to the people who are potentially affected? And further than that, can we actually design, in human interaction, human-computer interaction, we talk about affordances. What are the things that we design into the system that allow, in this case, the affected stakeholders to interact with oversight authorities? And, we use this sort of breakdown to try and conduct, research and discussions, not just in the sort of the technical areas of data governance, but also as a way to interact with scholars on the legal side, on the ethics side, social science, so we can break down the different concerns and try and resolve it to achieve this overall goal of trustworthy AI and data governance, so we can frame the situation more clearly. So data governance itself, as I said, is probably a slightly more mature area than trustworthy AI governance, which is still, a very fresh domain of scholarship. And already Ireland, as I mentioned, not only with its engagement with international standards bodies, but in multiple other avenues, has actually a quite strong array of data governance researchers and experts And one of the activities that ADAPT is involved in is the Empower Data Governance Spoke. So this is an industry academic research program sponsored by the SFI that actually brings together the data governance experts across several of the SFI research centres. So ADAPT, but also Insight, Future Neuro and Lero. And this breaks down issues of data governance, touching on a number of different issues: data markets, how we can put in, so how can we motivate organizations to better share their data, regulatory sandboxes, so how can we experiment? I think Philip used the excellent phrase, adaptive governance. So how can we actually experiment with our governance mechanisms? And also how can we bring in supportive tech solutions? So that can be in terms of privacy preserving technology, it can be in contributions to standards mechanisms and technical standards, but also there's a role to be played with in terms of mechanisms for engaging with the public. So we heard mention already of some of the work that we've done with IPOSI, engaging with patient groups to have open discussions about how their data should work, and we're expanding that into a series of thinkings addressing specifically AI and data ethics issues. So already we have I think a sort of quite mature network within Ireland, and this particular structure actually made it into the national AI strategy under the data governance pillar there. But beyond that, we are looking specifically at topics around health data sharing. So the topics you were hearing Vinny and Philip talk about, and in particular, looking ahead, already there are issues there around just overcoming the complexities of GDPR as it stands at the moment. But we're looking ahead to the raft of additional regulation that's coming into play there. So we had last year the draft of the AI Act was put into the European Parliament. We have the Data Governance Act also going through the Parliament, the Data Act, as well as other acts that may potentially impact on some of the commercial partners that we work with. So we see a real complexity, and if I was to put my sort of finger in the air, I say in terms of regulatory complexity, there's probably of an order of magnitude step up here in terms of the amount of regulation that health authorities and their collaborators on the research and the commercial side will have to do to deal with sharing health data. There's a real upstepping in complexity. Part of that is done with the aim to provide legislative support to improve setting up of data sharing. But there are other regulations in there that aim to protect, like GDPR privacy rights or data protection rights, but also other fundamental rights as well. And we have to deal with that, or practitioners having to deal with that. So, Vinny mentioned, for example, the FAIRVAS project, which is trying to look at sharing data across for rare diseases, vasculitis specifically across Europe. It's a real policy goal for the Commission. It's a practical goal for those researchers. We've helped them overcome some of the data interoperability issues, but there's still regulatory issues that vary country to country. GDPR doesn't always solve those problems, and we have to deal with those. But in addition to that, we also have vertical legislation related, for example, to medical devices, In Vitro Medical Devices Act, and then we have the local interpretations of those acts and the HSE and Health Research Consent Declaration Board policies there. So there's a large complexity that we have to deal with. And we use this overall model to sort of try and understand, well, what are the value chains? For example, if we, break down how we can, what is GDPR really doing here? We can sort of break this down, understand the different roles that are in play, and then analyze, both what are the signals that are exchanged between the oversight authorities, so data protection officers, the supervisory authorities that oversee them, perhaps the courts and the European Commission. What is the interaction between them and data subjects and the broader civil society that supports that? And that helps us articulate issues that we see specifically around, sometimes you see this in the commercial sector, what we call dark patterns, so ways of obtaining consent that aren't really being sort of fully clear and transparent with individual users. And the issue there is, that raises a level of mistrust in the population that we have to we have to deal with. And as I say, what we're looking to now is, how can we address that so that the sort of work we do is work on open, transparent data vocabularies that allow us to deal with things like linking privacy policies back to the legal text, so people can sort of trace back to see, well, which rights are actually being exercised, how can they track their consent, how can we track what processing has happened over data over time. So a lot of that can be exchanged between stakeholders, exchanged between users in a more transparent manner. And this is all done in a way that can lead into contributions to international standards. So this is some examples of work that we've done around data protection. We see the same now happening, or needs to be happening with the AI Act, which is a risk focused act that brings in some additional requirements based around risk assessment that's used in existing product certification mechanisms. So, the way you get these CE marks on the bottom of many products, that's now going to be in place for many types of AI products. And again, we do the same sort of analysis. We look at the legislation, at least the current draft legislation, and try and break down what are the signals going to be there, and what are the affordances? How are affected stakeholders going to be able to interact with the government processes? And by doing that, we can start analysing, well, where is there real need for greater transparency? How can we help, both by contribution to international standards and interacting with various stakeholders, digital rights activists, as well as the practitioners in the value chain, to try and make some of these concerns more interactive. And certainly our analysis of the AI Act at the moment is it's going in a very, it's probably going in the wrong direction. It's going in a very technocratic, non-transparent approach in terms of its mechanism. So one of the areas that we're doing is both providing the technical supports, but also, engaging in debates to try and make some of these interactions between the value chain, oversight authorities, and the affected stakeholders more transparent. So just to wrap up, this is a little example of some of the work we're doing currently, which is a mapping between how risk of AI systems is modeled in the AI Act, and how it can be supported by existing international standards. So, it allows us to provide a transparent model that we can contribute back into the international standardization activity. But it also provides us a basis for continuing our multidisciplinary research, trying to integrate across data protection, fundamental rights, and ethical and societal impact assessments, and also start working with stakeholder groups such as patient groups to look at how can we expose some of this information to enable them on a sort of case-by-case basis to have more transparency and understanding, and therefore a more informed say in how their data is being used by AI. So I think, just with the eye of time, I will leave it there and perhaps hand back to you, Olivia.
Thanks, Dave. I'll leave questions at this point because it will be difficult for Dave to hear us. But the next part of the agenda today is going to be a panel discussion. I'd like to invite the panelists and our chair up on stage. So I'm delighted to introduce Mr. Tom Loy, who is Director of Public Affairs and Communications here at Trinity College Dublin. He has extensive experience in media and journalism from his days as an editor and as a journalist. And along with that, he also has extensive experience with government and other stakeholders. So I'm going to hand over to Tom, who will introduce the panelists.
Well, good morning, everybody. It struck me that the first three people that we had today were all researchers, academics with a practical bent, whereas the panel are really practical people with an academic bent. So we're taking the same subject but coming at it from a slightly different angle. The idea is to talk about this issue of healthcare, AI and data for the next 45 minutes. We'll take about 30 minutes to have a conversation, and then we'll take your questions. So let me introduce your panel, and our first speaker, to use that old cliche, doesn't really need any introduction, but I will introduce him anyway. He's Dr. Ronan Glynn, who was, of course, the Deputy Chief Medical Officer at the Department of Health during the pandemic, and Ronan was also the acting Chief Medical Officer and the head of NEFIT for 6 months. What you perhaps don't know is that he's trained as a physiotherapist and as a medical doctor and has a PhD in surgical oncology and postgraduate qualifications in surgery, public health, healthcare quality, and safety and health systems leadership. So quite an interesting set of qualifications. Going from my right, our next panelist is Mary Day, who's Chief Executive of St. James's Hospital and an innovation enthusiast. Prior to this recent appointment, she served as Group Chief Executive of the Island East Hospital Group and was also the Chief Executive of the MARTA. So Mary has many years of practical experience in senior management in various parts of the health sector, driving change and quality improvements. To the right of Mary is Dr. Marcus Hessling. Now, he's also got great qualifications in this area. He's the Chief Medical Information Officer at Children's Health Ireland. And he's a consultant paediatrician at Temple Street who worked for nearly 25 years in the UK, most recently in Wales. His interest is in clinical informatics. When we were talking before this session began, he said to me very modestly that it's going to be his job to make sure that the Children's Hospital has about that for a second. That's neatly encapsulates what the challenges that we face. Finally is Dr. Lucy Hedeman, who's Director of the Centre for Health Informatics here in Trinity, and she is an expert in health research data integration. Her core area of research focuses really on incorporating clinical guideline knowledge into electronic healthcare records. So that's your panel, and as I say, we're going to take a few questions, and then I'm going to ask a few questions, and then we'll come to you. So let's start with data, and then we might go to AI, and let's start, Ronan, with where Philip Nolan kind of kicked off. Philip talked about the tension between getting health data in order to do research and improve healthcare, and the need to ensure that data is governed properly, that people's privacy is protected. I mean, how did you perceive that during the pandemic?
So I just got good morning everybody. I just got the end of Philip's talk, but certainly we've had multiple conversations over the last couple of years, obviously, around data. And I think there's a few home truths, and they have come up this morning in various elements of the presentations. But I think things that came through the pandemic that we have to be honest about is that too much of our data in this country is in silos. That won't come as a surprise to anybody in this audience. But I think there is, I know Philip referenced it as being in an article that he had seen as part of his preparation for this, but I think there is a reality here and elsewhere that we need to overcome interdisciplinary competition, and we need to look at how we work together to best utilize data, because on the one hand, I think if we're being honest, we sometimes sit behind the wall of, well, I can't share this data with you because it's within my organization, I'm not allowed. But I think there's a larger maybe conversation that we need to have about, well, do you actually want to share the data, and we want to work together as a team, and who are we actually doing this for? Is it for ourselves as professionals, or is it for the public and patients? So I think that's a key element. I suppose to overcome that tension, I think there are three core elements when it comes to data that we're going to have to address over the coming years. And again, they've come up this morning. The first is transparency. And I think it comes to the conversations that I pose here having. With my background, I still struggle with a lot of the terminology around AI. I struggle with understanding exactly what it is that's being promised by AI. So somehow, as a global community, we're going to have to look at the language that we're using, simplifying that language and making it clear to the public and to professionals who expect to use these technologies what it is that we're hoping that they'll do, and what value they can bring to people. So that's the first piece around communication and transparency. The second then is around protection. We saw the cybersecurity attack. I think it's a non-negotiable that we have to be able to provide assurances to people that if we're going to use their data and take their data, that we're going to hold it and use it in secure environments. And then I think the third, and it's a really important one, is around this issue of utility. So as policymakers, as legislators, as a country with limited funds, if we're going to spend money on bring this data together, and if we're going to ask people to share their data, then we have to, as a payback to that, we have to ensure that we're using their data to best effect. And I think at present we can't say that we're doing that. So I think utility is a key issue in the years ahead. We've got to be able to show people that we are getting value out of the data that we're collecting, and we need to be able to do that up front. As Philip said, there's no point in having the conversation at the start of the next pandemic about why we want people to share their data. We need to be doing that now on an ongoing basis, and I think there's a wider national conversation to be had around digital literacy and digital health.
I'm sorry, Tom, for interrupting. There's an acoustics issue just in the room, so this might help, but if the panellists could also just raise your voice, that would be great.
So shall I hand this around, Olivia?
Yes, that would be handy.
Okay, I might hand this to Mary. And Mary, I saw you nodding rigorously there when Ronan was talking. I mean, St. James's Hospital was one of the first in Ireland to have an electronic health record. And you've been capturing data for decades now, is it? Or
Well, no, not quite
not
decades.
quite decades,
We're
but
what,
years.
2000 and, yeah, about 5 years, yeah. My team are in the audience there.
Do you recognise a lot of what Ronan was saying there? And where do you see the big difficulty?
Yeah, so thank you very much. Good morning, everybody. And so I suppose really, I suppose in relation to electronic patient record, I suppose the first element of this in relation to fully take on board around sharing and being prepared and how we use the data. And I think there's another big element, I think that we have to grapple with as well, is around investment. So, I do think in 2022 to say, for the acute hospital to be the first to have electronic patient record in one way is quite a sad indictment in relation to the lack of investment that has been, I suppose, evolved around electronic patient records. And it's great to see that CHI, of course, on the campus will, also be combined, and we hope that this will be a fully digitalised campus going forward. But I think the huge importance of data from a service delivery and a service improvement perspective, to have that wealth of data in relation to electronic patient record is how we use it, and how do we use it for service efficiencies, how do we use it for service improvement. So I've been a huge advocate of looking at lean transformation and bringing lean into healthcare, and the data is a real driver in relation to enable us to do that. And also, I suppose, in relation to how we look at how we connect in with the system as well. So the St. James's Health Campus is, you can have a large children's hospital, an adult hospital, a university. We're linking in with our local community. We're linking in with the local area in relation to come to regeneration. So I suppose there's a huge different number of touch points in relation to where we need to pull that data. And, there may be elements of that that's very sophisticated, how we can pull the data. And there's other elements that's not as sophisticated. So we all need to, I suppose, raise in relation to how do we pull the data out of the community? How do GPs use the data? How does that data integrate in with the delivery of the acute system? So it's really about harnessing, I suppose, the data feeds that we have, and also it's investment. So it's going back to my first point, it's investing in the infrastructure that's required to ensure that this electronic patient record rolled out across the system, because if we're facing another pandemic, hopefully not too soon, but we will be, and they're still grappling that this that we can't get data out. Like, I think Philip's opening remarks were quite quite insightful in relation to the lack of data that was there, and using it at very archaic systems, so it just, I suppose, highlights in relation to that lack of investment that has been, that we have been subject to.
And then keeping it simple enough that we can all
absolutely
operate it and understand it. Yeah. Marcus, you're somebody who probably doesn't need it to be kept simple because you've been kind of thinking about this for a long time. But this ability to share data, which is critical to good healthcare outcomes, it offers all kinds of challenges. As a patient transitions across the system, maybe from child to teenager to adult, but also from different care types, how can AI and big data be used to improve the experience of the patient?
And I think there's no doubt that there are huge opportunities. So just to give you a few examples, so from a patient perspective, and I appreciate that Derek was in the audience earlier there. You can see if you get referred to secondary care, the first question people often have is, how long will it take? Yeah, the data is available in the system, but it's not available to the public. So you could talk about a digital front door to every hospital, where a lot of information could be presented to patients, really helpful. I think Vincent was talking about virtual reality, touched on that. For myself as a pediatrician, that actually has got huge potential to help little patients with their fears and anxieties. So huge opportunities for patients and to improve care and to make it easier for patients. Same goes for staff. You've mentioned information sharing, data sharing. When it comes to patient safety, it's all about having the right data at the right time to make decisions. That's still not happening. We're struggling across our own organization to share data, let alone across the wider network across the country. People talk about clinical decision support. They talk about the fact that machines never get tired. They are not affected by the fight they just had with their partner. At 2 o'clock in the morning, and if you think about if you're in any hospital at night, you're probably looked after by the most junior clinicians, and clinical decision support would be hugely beneficial. You talk about the problem we have with recruitment, certainly in terms of pattern recognition, so areas like, I know your dad is a radiologist, so he might not want me to say this, but there is certainly a place there, histopathology, ophthalmology, these are areas where we could really do with it. And I went to a talk a while ago by Ali Parsa. He's the guy who was the CEO of Babylon, and I remember him saying, when will it actually become illegal for us not to use that data? And I thought it was a really interesting take, turning it around. We're all saying, what can we do? But actually, when is it that we're saying, these things are here for us to use, but we're not using them?
Lucy, you seem to be nodding in rigorous agreement there. I mean, this is your area. So why don't we follow on from Marcus's question? I mean, how would you answer that? And how would you, is there any danger that we're going to be swimming in too much data anytime soon? Is that a danger?
AI researchers and clinical researchers never feel they're going to have too much data, and I think there are ways we can address, if we have too much of it. I think the problem is at the moment in Ireland in healthcare is we don't have enough data. And the first thing, on my set of notes is just to remember that St. James Hospital has an electronic healthcare record. There really isn't anything much else going on at that level in hospitals. And my long-term interest is in clinical decision support, the kinds of things that Marcus was talking about. And you can't do clinical decision support without electronic data. I've been teaching about clinical decision support for 20-something years, saying, okay, let's assume we have the electronic healthcare record. Now, how do you build intelligence on top of that? And I'm talking about simple intelligence, rules that say, but do the kinds of things Marcus was talking about. You don't want a tired junior doctor to be remembering to do in the middle of the night. Rule-based clinical decision support is fundamental to doing healthcare properly. And why are we not doing it? Well, first reason we're not doing it is we don't have electronic data on which to do that, right? So just to be really clear, you can't say, you can't have a system that says if you order prescribe, let's say, X drug to patient, then in 24 hours you must have a lab test which checks the levels of that drug in the patient. None of that can happen in an environment where you don't have electronic healthcare records. And it's not fancy data, it's not the kind of AI that ADAPT is really talking about here. This is just very fundamental. Without electronic healthcare records, you can't do any of that stuff. So it's criminal, really, that we're not doing that stuff. And why are we not doing that stuff? I was at a talk where we did something very similar to, I can't remember exactly the story, but how are you telling, it's about a grandchild talking to his grandparent saying, you mean, it was done in relation to self-driving cars. You mean you actually drove cars back then? And use that as an analogy for, how we're doing healthcare. It's like, it's gobsmacking, really. So just having electronic healthcare records is a big part of it. So I don't think big data, too much data is a problem yet. That would be my view. When you listen to Philip, yes, okay, there was lots of data coming from places, but that was in relation to COVID. It's not really like that for just everyday healthcare delivery in our hospitals across Ireland.
Other problem then is we don't have access to that data. It's hard to get access to a lot of this healthcare data. So I'm involved in various clinical research projects. I work with Mark Little in the Fairvast project, Orla Hardeman Precision ALS project. Big problems in all those projects is getting access to the data, getting access to enough data. So we still don't have a problem of too much data. We need better access. And a lot of the work that Dave Lewis has talked about is helping us in ADAPT to understand how to improve access to data, how to smooth that access to data, how to automate consent and access models. And so a lot of that is needed. So in basic answer to your question, no, I don't think too much data is a problem as of yet.
Okay, well, there seems to be quite a lot of gloominess on the panel about data. So why don't we make it even, talk about why we need data, which is in a way it's to do artificial intelligence. The next bit. I wonder, Mary, would you just pass the mic down? I'm going to turn to Ronan first. And Ronan, during the pandemic, one of the things that we saw was the great benefits that come from artificial intelligence in terms of bringing medicines to market very quickly. And that is perhaps one of the things that the public needs to perhaps understand better. What lessons would you say can we draw from that experience?
So I'd agree the public need to understand what the potential value is. We need to explain that better, but I think we also need to be better at explaining to the public where we are right now. So I'm not sure if Philip said this, but in the very early days, for certainly the first 2 weeks of the daily press conferences, we were doing a mad ring around the country, finding out, how many cases do you have in the East or the West or Cork or Galway or wherever today, what age are they male or female, writing it down in an Excel file, literally bringing together scraps of paper and just usually getting down to the press conference about half an hour too late because we'd been scrambling trying to get this information. And then sitting there trying to give a coherent narrative to the public about what was happening. So I think we have to be honest about the extent to which we're hampered. We have a health protection surveillance centre that collects data from departments of public health all around the country on countless, I think 100-odd notifiable diseases. And the data sits there and is not really being used to best effect. But ultimately, I was reflecting on this. I think for me, a key lesson from the pandemic, and it's probably a question that I don't know the answer to, and I'd put it back to the audience, is that what struck me is that we were very fortunate that Philip and the team of academics with Philip that came together did and could do what they did. But the question I would have is whether or not we are training the right people for the envisioned future that we have around AI and the wider health data space. So certainly within medicine, I don't think we're adequately training doctors to understand that the role of technology will have in their careers. Certainly in postgraduate medical training, we're not doing that. But wider than that, and this is the question I suppose I'd have, is are we training enough specialists in data architecture, in data analysis, in artificial intelligence, in communication and trust around health data and health technologies? And I don't know the answer to that, but I think if we're not, it's going to become a real issue in the years ahead.
Well, let's do a show of hands. Ronan's put it to the audience. How many people think that the number of people being trained to do these kind of things, these kind of tasks, is adequate? How many people think the number is not adequate, that we need more people? Yeah, it is that kind of audience, isn't it? But I think it's pretty straightforward, and that's really a huge problem that we could come at from so many different levels and different angles. But Lucy, from a research point of view, AI systems are reported to be able to help doctors with diagnosis, but systems are only as good as the data they have. How can this tension be rectified, especially building on your comments about there just not being enough data at the moment? But how can we do this?
That's a very tough question. And the first thing I'd like to say just is that AI actually hasn't been terribly good at diagnostics. That's not where AI in medicine has been strongest. It's been in the more routine stuff, in the, if we do this, then we should do that. Diagnosis has been much more difficult than was expected at the beginning, and it has been successful in very limited domains, but not in the sort of global way that people would have expected. But that's just a detail within that question. How to improve the availability of the data for AI, which I think was your question. It's really difficult. One thing I hadn't thought about until Philip mentioned something earlier. It came up, people not putting in the geocode because they don't understand the importance of that. And one of the things you need to do is, and it's true of data quality across all disciplines and domains, but in healthcare, is for the people who are entering data into systems to really understand the purpose to which that data is being put. And a very small example of that, but I had an MSc student many years ago who were looking at maternity in Drogheda or Dundalk, or wherever the hospital is, Our Lady of Lourdes Hospital. It's a very small example, but she was trying to improve the data which was available to public health nurses going out to visit mothers after they had their babies. And she brought those people together with the nurses in the labour ward and explained, they had a workshop where they explained what the public health nurse's job is. And it helped hugely with the improvement of the putting in of the data by the labour ward nurses, because it's the same sort of thing. If people who are being asked to put in geocodes for data don't understand the data, how that can work. So that's one way of helping with the quality of data, but it's a very slow and tedious sort of way of doing things, but it does need to be done. People need to understand the role of the data they have in order to have more complete data and better accuracy of data. The other part of this is, of course, something that was brought up earlier about bias and trying to ensure that the data sets that we have and that we're using for AI, for the building of models in AI, are representative of the populations for whom they're going to be used. And again, that's back to your question about the first question about having too much data. Very often we have an awful lot of data, but we don't have the data that reflects the situations in which we want to use the models that we're building with our AI. But to answer your overall question, how are we going to address the issues of data and having the right data for the AI? It's multifaceted, multi-pronged. There's an awful lot of work to be done. And it has to be done at different levels, technological levels, just better ways of integrating data, standards, health informatics standards, so that the data is understandable, can be harmonized, that we're all talking the same language, that when we talk about apples and you're talking about oranges, well, you're not talking about oranges, but also there's this sort of social aspect of people understanding the importance of the data. I'm not sure if I've really answered your question, but
I think you have. Thank you very much. Yeah. Can I turn to you, Mary? One of the big promises of AI is always efficiency, and something obviously that politicians and the public like is because there's this trope that hospitals are inefficient, that the public health service is inefficient. How is that working in practice for you? Are you able to achieve efficiencies in St. James's, say, through AI, or do you see that coming, or is it a little bit like what I was asking Lucy? It's not really the point of this?
I think probably the best answer to that, Tom, I think we're on a journey to deliver that. I suppose there's still a lot of research to enable that to happen, and research in what are the most optimal uses of AI, and how can we, I suppose, get the best value out of AI in relation to the clinical perspective, and also in relation to how we run hospitals, and how can we run hospitals better. I know in James's and O'Donnell's in the audience there, O'Donnell's done a lot of work around looking at the data lake, and where you have systems in place, how can you, I suppose, looking at developing that data lake component, which I'm not an expert on, but I can see how that can benefit. So, I suppose really to answer your question, I think that was one of the reasons I asked Philip that question in relation to how can the universities and the health systems work closer together to deliver. I suppose this journey that we're on, and to there is an element for investment. There's a piece around grant, but also I think there's also that collaboration between the university model and the health service model to actually learn together and to get better efficiencies and to get better outputs in relation to AI. What can AI do? And it's all about not having enough data, but also I think it's about having protected time within the service delivery side to enable you to invest into this, not just from a a money component, but also having, you know, time element, because unfortunately in healthcare we're time poor. So I think that's another important part, and I suppose it builds up to what we're very keen on developing around, you know, St. James's, we're working with our partners in Trinity, is around that whole element of the academic health science, that you have an academic health science campus where you've got the clinicians, the scientists, the data people, and the service users all working together. And I think if you get those working together, then you can get better outputs and better benefits.
Yeah, I think it's
so we're still in a journey, I suppose, really is what I'm trying to say.
The public struggles to understand that what a university hospital is, doesn't it?
Yeah.
That it really is about deep collaboration.
Absolutely.
It's not some kind of branding exercise or some nonsense like that.
And I think if you look at the Mercer's Institute of Aging and looking in relation to what we're looking at, the longitudinal study we're doing around Tilda, even what we're trying to do in cancer, I think is a really good example of that.
Because you came to Ireland relatively recently, I think last September, and your experience has been mainly gathered abroad. Is Ireland, are we in a good place, do you think, to introduce this kind of technology, and what are the likely indicators that we're going to succeed as a system?
It's a trick question. I have to be very careful. The audience is largely Irish, I'm assuming. So one of the things that actually attracted me to this particular post was that at CHI we now have people like myself, but from all professions. So we have a HSCP information officer, we have a nursing information officer, we have a pharmacy officer, so representing really the whole spectrum, and that's quite unique. I don't think that exists in Ireland, and I don't think it exists in many places. And Ronan was mentioned it earlier about the training of doctors. I would go further and say it's training of clinicians. We need more people like me, not me personally, you really wouldn't want that, but you certainly need more clinicians who understand data. You know, I'm not being too critical, just picking up on the points earlier. You know, St. James's is the only place that has got an EHR, and clearly that's the way we're going to go. So I would say this is a good start, but in international comparison, we are probably still very much behind. And one of the issues I can see is that everybody is in favor of all of these things, so that there's a huge mismatch between the opportunities and the actual resources that we are supposed to be putting in. So people talk about data as the new oil. I don't see the refineries being built. I don't see many opportunities for people to get into the health data, and especially clinical people having opportunities to focus on it. So my job is 80% focused on this, whereas I do 1 day a week clinical, and I think that's really important to give people the opportunity. Neil O'Hare was very clear that we need to do more research, and wants to have us 20% of our time dedicated to research, and I think that's going to be really important, but we need to give people the opportunities.
Can I'm going to come to the audience in a second, but can I ask one last question of the panel, and I'd just be very interested in a brief answer from each of you, if you don't mind, and we'll start with you, Marcus. To follow up on something Philip Nolan said, which was that he thought that the public are able to kind of distinguish when they want to give up privacy, when they want to give up their rights, and when they want to keep them. I'm not 100% sure that's correct, although of course I hesitate ever to disagree with the head of SFI. But I mean, would you agree? Do you think that there is enough public understanding to kind of give up some of our privacy rights? And what do you think is the big blocker here?
I think it was mentioned in the talk earlier about trust. It's really interesting. I find it amazing that people quite happily are on their smartphone all the time when data is collected, no doubt, from companies all over the world. But when it comes to their own health, they're like, ooh, I'd rather you not. So I think that trust is massively important.
Lucy, what do you think?
Yeah, I think it's all about trust as well. I think that we do need to find ways to harness the willingness of patients to contribute their health data. Particularly patients with rare diseases are very keen to have their data used for research because they really understand the shortage. But many other patients are able to do that. I think Philip said, I think he's right, the fear of it being used by the private sector, and I think that's an understandable and genuine fear. But you're right, given that we all give away our data to Meta of some sort every day, but somehow or other, when it's health, I guess we feel we shouldn't have to. And whereas when it's, I want to play a game on my phone, it's ridiculous, really, isn't it? But I think, again, there's a big job to be done there, at this sort of tedious job of education and training and communication and harnessing the opportunities. I mean, Philip said it, he was right. If we had set that tracker app up so that we could add and ask for further consents as we went along, we would have had opportunities to explain and to bring people along on that journey. Whereas we started with that very conservative attitude and we didn't. Dave mentioned also the need for the AI regulations or AI bill or law, or whatever he was talking about, to be about broad spectrum approaches to AI and allow governments to, or maybe it was Philip also said it, to adapt as we go along to what's possible and what patients will allow. But it's, again, going to be hard work, and it's a very social sort of problem. It's not a technical problem.
Mary, how do you find that? How do you find the patients in St. James's are around privacy? Is that a big issue, or is it something that it's just a GDPR thing, it's a bit abstract?
Yeah, just before I answer that question, I just want to just comment. I know James's are the first to evolve an electronic patient record. I know Tala actually are developing electronic patient record that matters. So it is beginning. I suppose the problem in relation to, just going back to EPR, is that we don't have one incidence, or there isn't sort of a national investment in this one instance of EPR. Anyway, I don't want to upset our friends in Tala, just think we're being a bit superior here, but we were the first. Just in relation to GDPR, I think sometimes it can be there to hide behind. I think going back to that, I was just going to say, I think there's an element about trust and there's an element about education. I do think we need to move away from a healthcare model to a model of health. So what we haven't really been educating, and I know Sláinte care, it's coming out there, but it needs to be more at the forefront, is how do you keep the population healthy and how do you invest in relation to keeping the population healthy. And I think if there was a different dialogue in relation to that, you may get much more openness in relation to from data. But I think on the whole, in fairness, I suppose predominantly around looking at research and clinical trials and engaging more and more patients in relation to clinical trials, it's understanding and education is key. I think you're always going to get that element of hiding behind GDPR, and I think even we do it to ourselves, not just in our patients. I know as a health system we do it to each other, and there's a big issue going on at the moment in relation to data sharing certain areas around scheduled care. And it's an interesting dialogue we're having even at our own sort of system level, not even at a patient level. So yeah, I would concur with the panel. I think it's more about trust, but I think it's really more about education and understanding, and as I said, moving into that health model rather than a healthcare model.
So Ronan, you said in your opening remarks that there's sometimes a reluctance to share data, and clearly the issue of trust has come up many times. Is there anything you'd like to add to that, or do you think that covers it?
I mean, from the evidence that we have, I think it's pretty clear the public do want us to use this data appropriately. So HICWA have done work which clearly shows that 9 out of 10 people want electronic patient record. They want doctors to be able to see their data. So I think we're coming from a relatively good starting point, but to kind of reflect on what Mary said, the reality is that 90% of what affects our health happens outside the health system. And the reality is that whether we like it or not as a health care system, the public are getting on with using data for their health across their lives, with wearables, etc., etc. So my own view is that one way or another, the public are going to be sharing health data over the next number of years. But it comes back to another point I had, which is that I really think, given the extent to which data is being used by individuals and then the extent to which we want to use that data as a health system, and also given the impact that the wider digital space has on people's health, I really think that we need to look at how we're educating our primary school and secondary school students into the future about data, about so we know we've very good health literacy in this country. The question is, can we translate that into digital health literacy over the years to come? And I think that will be a key part of keeping the public with us. And the last part, just reflecting on the pandemic, is the public are a key cohort that we need to engage with. The media are another cohort that we need to engage with, because headlines about Big Brother and surveillance is really, really destructive to what the people in this room are trying to do in the years ahead. So I think we need to have honest conversations with our media counterparts as well.
Good luck with that. Let's turn to the people in the room. Let's take a few questions over there. Yeah. Sorry, the lady in the dress.
Yeah, thanks very much. And again, commenting from the Health Research Board perspective, where for many years we've tried to encourage public and patient involvement. I just wanted to comment on, actually it was David Lewis's talk that he's not here, but in terms of the governance, the model was quite linear, with the user at one end and the data provider over here at another end. So rather than that, we should be probably thinking about a value network rather than a value chain. And this is talking about, you know, the data providers, the quality issues that Lucy has brought up. But who are the users? Is it technology push or is it user pull? Be they clinicians needing decision support, be they users wanting to maintain their health versus healthcare. I think those are really important point that Mary brought up. But I think it would be very interesting to see the kind of the larger research programs building in involvement in the governance structures, in the research questions that are being asked, why are they being asked, what's the need for it, and so on. And in that way, you can kind of guard against some of this. So I don't see this as necessarily public education is one strand, very important, but it's the involvement actually, because it's our data, it's all of our data. It's our personal, private, sensitive data. So we kind of need to address this as early on as possible. Estonia have managed it very well, right? They've really engaged kind of public. And the other thing I would plea is when you're talking about this, when you're thinking about your systems, please think about cross-border data sharing, because the EHDS legislation has been published. There's going to be, you know, your kind of summary record, the sharing cross-border data. It's coming down the line in a couple of years. So let's not just think about Ireland, let's think globally, you know, interoperability standards and so on. So it's great to hear these conversations going on. It's really interesting to hear your comments.
Funny, whenever one has conversations like this, Estonia invariably kind of crops up at some stage. I'm just going to ask Lucy for a quick kind of response, and then we'll move on to the next question.
What you're talking about, Vinny's introduction about ADAPT and the human-centric AI piece, I think is exactly what you're talking about there. Admittedly, Dave's model didn't reflect that holistic sort of bringing the human into the thing, but I think the overall trust of ADAPT and ADAPT's research is what you're talking about, having the human as part of the conversation about the AI we want, having, and that's on many, many levels, and you know, the people who are using the AI being thought about when that's being designed, the interfaces, having AI, having humans as part of the decision loop, not having it completely automated. That's been a long theme of ADAPT. Patient involvement, public engagement is very much part of what we're doing in ADAPT. But you're absolutely right, and it's not just education. I do think I said bringing people along as opposed to, well, as you mentioned, education.
I would agree with you. Every time you talk to Vinny, that's his core thing. I might just go to another question. Sorry, there's quite a lot. Over here in the shirt first. Yeah.
Thanks very much. Mark Little, I'm from Trinity and Tala Hospital. And Ronan and I, probably one of the few people who've managed, I think, to get CIDR data to work for research, although we were having to scrape the data from PDFs, which was enormously painful. But a question really for Mary and Marcus, really, from a pragmatic perspective, as patients transition primary and secondary care, how do we deal with consent? How do we manage this? Because if we want to use the data for research, as it currently stands with the health research regulations, and that may change, we need to have consent.
So as people move from the primary care into the secondary market, is it as like if you're looking at
Even just in secondary care in St James's Hospital, we've got a lovely EHR there. We'd love to use it for data, but we don't have consent.
consent from the patient? Yeah, so that's a difficult question. Yeah, thanks very much, Mark, in relation to do that. So is it like from an organisation? Is it from, like, I know the whole issue of consent is huge in relation to like how we get consent for information. I know from in cancer we're doing a piece of work around it at the moment in relation to looking at, as you know, we had a talk there from Mark Lawler in Northern Ireland in relation to looking at big data and what he's doing around the that whole area in Northern Ireland in relation to getting that from cancer, and it's something, I know if you talk to John Kennedy, he'd have a lot of things to say around how do we influence it, and we did, I suppose, try to even just influence it politically in relation to how do we get consent and how do we break down some of the barriers in relation to developing consent. But I'm not sure exactly what you're thinking of.
The reality is that when you try and do research, the first thing you're asked is, has the patient given consent?
Yeah.
And when you try and publish, you have to say every
Yeah.
single person has given consent.
Yeah.
Or you've had some kind of
Yeah.
waiver by the government. So are we kind of talking about, as the people come through the door of St James's, are they going to be asked to sign that?
Yeah.
You know, I mean, that's one approach.
Yeah, that's something like we haven't discussed that, but like in fairness, I suppose that would be one of the areas we're looking at is developing. I suppose you're developing an academic health science centre and you're very much a research-rich campus. That would be an area that you could look at, but I suppose we haven't. To be honest with you, Mark, we haven't really gone into that sort of element yet. But thanks for the question. You've now given me something to think about.
I think it has to be a two-pronged approach. There has to be a national approach to this. I mean, Estonia was mentioned, but if you look at the culture in Estonia, it's completely different in terms of the look at authority. Yeah, and I would argue that in Ireland, authority has been dented massively, and people are really wary of authority. So there's then the national component, and then there is the individual component, where at every opportunity we do need to inform our patients that we would like to use their data, and we need to explain to them why it's really important, why it's beneficial to them, why it's better for them that we do that rather than not do that.
Okay, we're going to turn to, is there anyone from this side of the room? You. Yep.
Is there any way, is HSE interested in getting data from third parties? So, for example, wearable health tracking devices. Majority of population, so many people have like health tracking devices, Apple Watch, Garmin Watch, Fitbit. So, will it not be like HSE would not be interested in managing population health with help of like integrating data from these devices, which like people wear most of the time during their day, during various activities, rather than just having one typical channel like getting data from GPs and stuff. So I'm just wondering, like from third parties, is that something which would help HSE in the long run in managing public health?
So I better be careful not to speak for the HSE. That's one mistake not to make. But what I would say is that certainly from a public health perspective, so I think in the last couple of years people have heard a lot more about the health protection side of public health, so contact tracing and managing outbreaks. But there's a whole other element of public health which is around prevention. And we have initiatives like Healthy Ireland, healthy communities, healthy cities, and I think we're hopefully going to see a much stronger impetus in that regard in the years ahead. And one part of that is the development of the CHOs and the much smaller community health areas across the country. And ultimately it comes back to the push versus pull. And on the one hand, we'll have clinicians who want some of this data, but ultimately I think what's going to drive this here and internationally is that patients are going to be saying, I have all this information, doctor, why are you not using it? I have all this information, physio, why are you not using it? So I think one way or another, it's going to be pushed onto the healthcare community, whether we like it or not, in the years ahead. And there is an onus on us then at policy level and within the HSE to ensure that we're developing the structures to be able to integrate that data, I think.
So, patient power is going to draw this. Now, I've let this conversation run 10 minutes longer than it should, so my apologies to Olivia and Vinny, and I'll have to call it there. So thank you very much to the panel, and thank you very much for all your questions.
Thanks everybody for joining the panel. So the final part of the agenda, I'd like to introduce my colleague Declan McKibben, who is Executive Director at the ADAPT Centre, and he is going to bring you through some of the structures and the opportunities that are in place in terms of collaboration.
Great, thank you, Olivia, and thanks to Tom and the rest of the panelists. That was a really interesting discussion. In fact, all of the talks this morning, I think, have been amazing, so thank you for that. I had a picture here, but it's gone now, but if you can imagine 100 years ago, this is Regent House, and 100 years ago, this was the site of the Irish Convention, which was a big think-in, a citizen engagement to some extent, or certainly of their representatives, to deal with issues of kind of home rule and the thorny issues of the time. Quite a different context over 100 years ago. It was all men, of course. Unfortunately, it didn't come to anything, but and the people then probably could not have imagined some of the ideas and the topics that are being discussed today around artificial intelligence and data. But what I kind of sense today, though, that there's much more unity around kind of purpose and a shared understanding of the challenges facing us as we kind of deal with these thorny issues, and that we have some common objectives around it. So I'm kind of much more hopeful going forward. Okay, so my name is Declan McKibben, and I'm the Executive Director in ADAPT. I'm responsible for commercialization activity, which is mostly collaboration with industry, collaborative research projects. Overall, the discussions today I just thought were super. Clearly, there's a huge opportunity in health for data and for AI-driven innovation, and a recognition of some of the key challenges around custodianship of the data, dealing with governance and privacy and data quality. Philip's talk was really illuminating and insightful, I thought. The learnings from the pandemic, the challenges in collecting data, in integrating systems and legacy systems, but also then on top of that, the integration between data itself and data harmonization and standards. So huge extant issues to be addressed, and it's a key focus, of course, within the ADAPT Research Centre. I also kind of like the way he characterized the opportunity here, you know, meaty but manageable. And I think that's going to be our kind of slogan going forward, you know, not to kind of bite off too much, but certainly to be ambitious and be realistic as we seek multidisciplinary collaborations. During Vinny's talk earlier as well, you'll have heard that ADAPT is a large-scale SFI-funded research centre. So we have more than 80 professors across our 8 host institutions. We have 100 million euros in funding for the 6 years of our phase 2. We're now in the second year of that. It runs till the end of 2026. And we've more than 400 researchers. So that includes PhD students and postdocs and research fellows. The PhD students one is really important. We're part of a number of centres for researcher training, and training PhDs is really about building capacity in the system. So it's such an important part, and many of the people spoke about that earlier. So by international standards, ADAPT is a large-scale research centre of some repute. We're reviewed every couple of years by an international panel of peers, and ADAPT consistently ranks top internationally, which is really, really great. And it's this scale and ADAPT's expertise and our research vision, as you heard from Vinny, they're just some of the reasons that these leading global brands, like I know Meta was there, Lucy mentioned it earlier in a different context, but you can see some of the other kind of global brands that we work with, and they come to us because they recognize ADAPT as a key source of this expertise. You'll have heard earlier from Vinny in the talk about human-centric AI, and Dave around the data dimension, that these are 4 research focuses for ADAPT, and in particular how they're applied in a health context, and solving the big challenges around user and data and context modeling, in data governance and in privacy, in classification, in prediction, user interaction, AI governance, of course, really important, as well as data governance. And it's all towards precision medicine and coming up with a sort of a personal understanding of what the patient needs are. The approach, of course, translates to lots of other sectors. It's not just health. So we're active in fintech, in ICT, in media, in retail, in gaming. because it's all about people and data and advanced technology and the application of AI to deliver products and services and meaningful and valuable experiences, digital experiences. And what's common in all the collaborations that we're driving is that it's never just one competence area that's required. To really move the needle, it requires multidisciplinary collaboration. And so where we draw together expertise from different perspectives. So in computer science, it could be information retrieval or natural language processing, user modeling, or personalization, as I mentioned, to advance the state of the art, for example, in recommender systems. But in many other areas, it requires domain expertise, data understanding, knowledge of highly regulated environments like Dave Lewis referred to earlier to really make an impact. And ADAPT, one of the things we're really known for is successful interdisciplinary collaboration, multidisciplinary collaboration. So whether it's across neuroscience, psychology, medicine, law, engineering, or sociology, not yet veterinary, but to Philip's point, we might have another look at that, Vinny. But for computer scientists to really understand the clinical data, they need to work with clinicians, and we do that. We work with clinicians and clinical researchers and also patients through IPOSI and other groups and carers, and importantly, with industry. So within industry, you know, the industry collaboration ADAPT is really important. Of course, we do basic and foundational research, and we're very active in European research programs, but industry in particular is important, you know, because it's good for research. It provides real world problems and scenarios and use cases and opportunities to access or generate new data sets for research. So much data is being created outside of universities now, and there's often an imbalance where actually a lot of the really interesting, valuable data is happening in industry. But also working with industry, it's good for the economy, obviously, and good for society. So with a third of our funding coming from industry, it's important that we're set up to collaborate well with industry. So over on the left there, that's our platform research teams. These are the PhD students and the postdocs and the research fellows led by the professors, the 80+ professors across our institutions. And the key here is the Design and Innovation Lab and our dedicated business management team. So it's those groups that make it easy for industry to connect with ADAPT's large-scale multidisciplinary research capability. We're all about understanding industry's objectives, to engage the right team of experts, and to structure and deliver those engagements successfully. So within the Design Innovation Lab, we have project managers, and we have designers, and we have research engineers, and we have obviously postdocs as well. And the business management team, it's myself, my colleague Edmund and Connor, and Kieran, I think, is here as well. We come from industry, so we've worked in industry. We understand the timelines, we understand the objectives and the needs, and we try and align those and interpret those for our colleagues in research. So within the team, there's the faces there. So we've got Connor, Kieran, and Edmund. But importantly, we've also got an IP manager, because contracts and IP needs to be managed, and we try and make this as seamless as possible. So we have capacity through DLab that I mentioned earlier for quick wins, and this is often appealing to industry because they can't wait a year or 4 years for a PhD studentship to conclude. So we're set up for delivering quick wins, proof of concept demonstrators and prototypes, enabling a tangible evaluation of the potential of the research. At the same time, we have the depth and the breadth of expertise for longer term, larger scale projects addressing bigger challenges and research questions. So in a kind of a multi-partner context, this is spokes that we're involved in, like Empower earlier, Precision ALS that Vinny mentioned. These are 4-year programs, 10 million euros funding for them, but also multi-year projects that we're doing with a number of our industry partners. And I think they're really testament to successful collaboration with industry when they come back for more. And it's these successive projects that we build trust in, and we get into doing really interesting research. We have from a portfolio perspective, we have a range of collaboration options. These include targeted collaborative research projects, postdoctoral researcher collaboration and placements and internships, and PhD studentships as well, and co-funding on those. Again, the importance of building capacity in the system for Ireland. We've also got a dedicated EU team. So in order, if your company is interested in accessing European funding, whether it's Horizon Europe or some of the Marie Curie postdoctoral research fellowships, we can help with that, and we're certainly happy to engage with it. So just I think my penultimate slide. Our strength lies in the breadth and the excellence of our expertise, that it spans thought leaders in computer science, but other disciplines across our partner institutions. So it gives us this capability and also a culture for excellent interdisciplinary research. It's not something that comes easy. And when I came into to ADAPT a number of years ago, I was kind of surprised at kind of sometimes a reticence for people from different disciplines to collaborate together. And Vinny, as the leader of ADAPT, has established this platform that lends itself naturally to that multidisciplinary collaboration and also fosters a culture around it as well. We're focused, of course, on human-centric AI and a commitment to collaborate for impact for industry. So it's not just a case of, you know, designing a project with industry, getting funded for it and kind of walking away. This is very much about delivering value and impact. It's important as well to emphasize that ADAPT provides access to these experts, drawing in the required expertise as needed. So our business development team helps with that matchmaking and that alignment. And some of the topics here you will have seen on Vinny's slide earlier, there's many, but you know, we're talking about AI for content and media analytics across all modalities. So it's text and it's image and it's graphics and it's AR and it's VR, it's speech. It's human computer interaction, it's machine learning and knowledge and data engineering. And then outside of computer science and engineering, it's key collaborating disciplines like clinical research and healthcare, psychology, business law, and sociology. And we're very much, from an industry engagement perspective, we're focused on having this structured, professional, and scalable platform for collaborating with industry and with other partners. We have a single framework collaboration agreement, and this is important because I think some of the views I've heard from industry in the past has been sometimes it's difficult to work with universities because you kind of form a bilateral legal agreement with one individual researcher, and then you have to have multiples of those if you want to kind of have a multiple experts or a multidisciplinary project. So we provide a single door into this expertise and a framework agreement that makes it easy logistically to collaborate. It's one door. So I'd encourage you in the lunch just immediately following this is do get in touch, talk to myself, my colleagues. You can get in touch for those who are on catch up at collaboration at adaptcentre.ie. And if you don't get a chance to talk to myself or my business development colleagues, please do talk to ADAPT experts who are in the room. I'm looking at Rosanna and Lucy right here. There's Vinny, Dave isn't here, but Mark Little is here. And I think there are several others as well. So be sure to talk. So it just remains for me to say thank you for all the contributions today. Thank you for showing up. It's great to have an in-person event. It feels right and normal. The acoustics weren't too bad considering the city centre location and single glazed windows over there. The food will be arriving momentarily, so please do stay for lunch. We'll be lunching and networking till about 12:30. We have another event starting at 12:30. So for those who aren't staying on for that, please make your way down the stairs when you're well fed and networked. And for anybody who's staying on, we'll see you after 12:30. So thanks again for coming today and for everybody for taking part.